This lecture is going to be covering EMS operations, start triage, mass casualty incidents, and our EMS response to terrorism. So having knowledge of operations, your role and your responsibilities in a mass casualty incident, in an act of terrorism, really plays into your being an optimal EMT. And it all starts with your personal safety. So to operate an EMS call, there are different phases. We have our pre-dispatch procedures, what's happened right up to the time when someone's called 911. The actual dispatch of the ambulances, the response of the ambulance, and the transport to the hospital, and then what the ambulance does after the run is required to be decontaminated, restocked, etc. So we always have to practice good driving procedures, and really taking an emergency vehicle operator course or a certified emergency vehicle operator course is only going to enhance your ability to drive an ambulance effectively and prevent things like this from happening. Safety is paramount on anything, and of course the safety of the most important person at the emergency is singular above all else, and the most important person at the scene of any emergency is you. So providing for your safety is key. Having the ability to have safety equipment available. Remember, in New York State, operating at the scene of a motor vehicle crash, we have safety vests that you need to wear. Prevent being struck by a vehicle because they didn't see you. Having those safety vests are paramount and should be used. In addition to the safety vests, depending on the scene that we're at, we have our personal protective equipment, turnout gear, helmets, blood and needle prevention, impermeable gloves, stuff like that, and leather gloves for extrication purposes, and even carrying someone down the stairs in a stair chair using gloves can just add to your safety. New vehicles that are being created now that are part of the Department of Transportation standard class of ambulance design. We have the new supplemental restraint systems, we have the new braking systems, but realize that these vehicle safety systems that are in the ambulance are also in all the other vehicles. So when there's a problem with these vehicles, especially with fires and stuff, these safety devices can become dangerous to responders. These shock, for example, we mentioned on the slide, these shock absorbing bumpers, okay, they can be loaded, and when they're overheated, they'll fire out like a missile. So always approach a car fire from the side. Airbags that have not been deployed are at risk for being deployed at any time. So staying within 5 inches of an airbag that's about to be deployed is dangerous. One thing that you want to think about is trying to deploy the airbag, and some systems incorporate you to take a Halligan tool and slam the passenger seat down. So putting that pressure on the passenger seat will actually deploy that airbag. You don't want the deployment to occur when you put your knees as you're crawling into the car to assess the driver. The airbag deploys against your side, it can cause some damage. So, staying on extrication, the fundamentals of it. First, where are you going to arrive? Where are you going to park the ambulance? You want to have it at a safe location. At a hazardous materials incident, it's always uphill and upwind from the hazard. We have our emergency lights. There are some systems where they want you to turn off the red emergency lights and put on the yellow lights. These yellow lights are actually not going to attract drunk drivers towards your vehicle. So once again, you go to whatever system you work for and find out what type of lights you're going to be using at a highway scene. Hazardous material scenes, of course, the uphill, upwind is always good. When you get out of that vehicle, you got to have that 360 mentality. You look around and have what we call situational awareness. Don't focus on the incident itself. Look around and make sure you're taking everything in. What time of day is it? What's traffic like? Where are we parked? All right, is there another vehicle? Don't get focused on that one part of the job that looks the worst. There could be other issues going around. Evaluate at this time as you size up the scene. What are you going to need? More extrication equipment, fire department, hazmat? Are there down power lines? Do we need the police, advanced life support? Would we have to land a helicopter? If so, where are we going to do it? These are all important things you want to figure out during your scene size up. We're going to be coordinating with other agencies, so we need to be able to speak their language and always put the patient's needs as at the forefront. You're there for the soft tissue. Let everybody else worry about the hard tissue. You're there for the soft tissue. So, and then make sure that you keep their needs the priority of the other response agencies. Sometimes they get caught up in safety issues or cutting a car and they forget about the patient. So it's our job to assess and provide medical care for the patients involved in this event. We also, in the situation of multiple patients, we need to be able to triage, sort through which ones are most critical and need to leave first versus those that can wait a little while. How we're going to package these patients is determined upon the location of the patient, their complaint, any issues of movement. These are all part of how we're going to package them. And then getting them to the hospital is the ultimate goal. So once again, law enforcement is there for public safety and hazard control. They direct traffic, they can control traffic, they can shut down a highway, they can maintain order at the scene. They're there to make sure no one interferes with your ability to provide patient care. Firefighters, responsible for any issues with, of course, fire suppression, but also hazardous materials, and that's part of scene safety. Downed electrical wires are commonly found, especially in rural areas, at the scene of motor vehicle crashes. Also in severe weather emergencies. Storms will down power lines. Assume that every down power line is live, and you need to have the proper utility company response before you enter in. You establish safety zones with the other responding agencies. And the most important zone that we establish is the hot zone. The hot zone is the area where there's a high risk probability of injury from things like sharp metal edges, broken glass, any type of chemicals, lethals, things like lethal rays like gamma radiation, and then anything that has the potential for ignition and explosion. So you limit the amount of people that should be in a hot zone, and you base it upon why this is a hot zone. People who should not be in a hot zone are people who are not part of the rescue and recovery response. So that includes bystanders. They can easily become patients. And the vehicle itself is a hazard. So if the vehicle is not righted itself, it's not on four wheels, or it's smoking, this is a potential disaster. So we have to treat this as a hazardous space. New vehicles with their alternate fuel systems, like hydrogen cells and batteries, they have other types of hazardous materials. I mean, a vehicle fire is probably one of the worst fires that you can respond to because it involves all classes of flammable material. So, you know, it's just not good with simple water. You might need a foam response. There's all different types of ways to put out a car fire. But now with the new cars, the alternative fuels, hybrid fuels, there's fuels like propane and natural gas. This is something that's an issue. So once again, fire service, fire suppression, if you're part of that rescue team, you understand exactly how to disconnect batteries, how to understand that there may be more than one battery and these batteries might be leaking and there could be an issue with acids. So this is something that's best left to people who have knowledge. Being an EMT, you probably don't have basic knowledge of this. So either educate yourself, but also get involved departments who know how to handle this type of issue. These are specialized systems, and we have them available. So put them to use. Specialized teams like for cave rescue, a confined space, dive teams, mine rescues, ski rescue teams, right? All of these are in place to assist with the recovery of a patient. Your focus as an EMT is to deal with the patient. If you have specialized teams that can assist you, all the better for you. You know, then we talk about law enforcement specialized teams like SWAT and rope rescue. All different types of technical rescue teams are out there to assist in extrication of patients. Now in 2004, there was a national order to implement the National Incident Management System. This is a federal order. It was passed by the White House, and it says that we have to all speak the same language, and we have to be able to work together for a common goal. Whether you're a private organization or a government organization, you're working together for a common goal. And in our case as EMTs, it's to provide optimal patient care. The organizational structure of the NIMS response is going to be flexible and easily adaptable, but we use the same language, the same terminology, resource classification, personnel is all trained the same way, and they're all given the same certification. In fact, in New York State, it's mandatory for all EMTs and paramedics to undergo this incident command training. And part of this training includes command and management of a scene, how to prepare for an event, understanding how to manage the resources and communicate not only inter-facility but also to the public. Understand who pays for all this, how we maintain a supply, a stockpile that we can be easily deployed in the event of an emergency. And a mass casualty incident is that type of emergency that we're talking about. It's anything that requires a mutual aid response. So what you want to ask yourself as an EMT, how many patients do I have? And what happens when you have 3 or more? You're going to need another ambulance. How long is it going to take for that additional help to show up? And what do you do in an instance where what you have overwhelms more than what you have available? What resources are out there for you that can assist you? Realize that in MCI, abandonment issues can take place. You can't leave the scene leaving patients behind just because you have to treat a more seriously injured patient. So understanding that you need the help and requesting it early is going to be for optimal patient care. Not just for the patients that are stable and eventually be transported, but also for your red patients that you have to get off the scene. So first arriving unit does what we call triage. And triage is French, it means to sort. So you want to sort the severity of injuries. All right, and it's a basic assessment. And it's a field assessment. Secondary triage is done once that primary triage is performed and you've classified everybody at the scene, then you can go and reassess them. We categorize our immediate patients as red, our delayed are yellow, our minor are green, the walking wounded, and then we have our black patients. So, what makes red patients? Well, like I like to incorporate is something called 32 can do. This is an element of START triage. And when you walk up to somebody and you ask them, you just ask them one question. You walk up and you say, what's going on? What's bothering you? Okay? and you do the 32 can do, are they breathing at a rate of 30 or greater? Is their capillary refill less than 2 or greater than 2? Can they say and do different things? If there's a problem with the 32 can do, their respirations are above 30, their cap refill is greater than 2, and they can't say or do different things, if any one of those things takes place, they're red. And we move on to the next patient. If they can say those, but for some reason they weren't able to walk to the greens where you directed all the greens to go to first, they're yellow. So these are some typical injuries you're going to see when you're triaging out patients. And then once you've classified and you're sorted all your patients, then we incorporate something called get the red out. Get all the reds out first and then the yellows. Can a yellow turn into a red and can a green turn into a red? Absolutely. Can a red turn into a black or a yellow turn into a black? Absolutely. It's a dynamic process. That's the elements of STAR triage. Walk up to the first patient you see with the least amount of injuries. It's the weirdest thing to think about. It's the least amount of injury. The person who has survived the event with barely a scratch, okay, that unbreakable character. And you walk up to them, you identify yourself, and you ask them if they have any complaints, and have them move over to a safe location. Then you address the group as a whole. And you tell them that where they are right now is kind of unsafe. You're going to get them, you know, their family's going to be notified, everything's going to be fine, but right now you need them to leave this scene. And you see that guy standing over there in a safe location? Could you just walk over to that safe location? And all the people that walk over to that safe location, guess what they are? They're green. They're walking wounded. We'll process them later, but we've got some other people we've got to take care of, the ones that didn't walk over to the greens. And then through the process of 32 can do, we can determine whether they're red or yellow. If their breathing is 30 or greater, they're red. We stop the assessment, red tag them, move to the next one. They're breathing at 20, their cap refill is a second, but they're in and out of consciousness, they can't say or do things, we make them yellow. I'm sorry, we make them red, because there's a problem with the can do. One of those things is a red flag. But if we walk up to somebody and his respirations are 20, his cap refill is less than 2 seconds, and he can say and do different things, he can tell you exactly what's going on, but he didn't walk over to the greens, he's a yellow. That's the process of 32 can do in START triage. What you're doing when you think about it is you're assessing their airway. They're breathing at a rate of 20. Their cap refill is good, that's their circulatory status. And then they can say or do is their mentation. Now if you walk up to somebody and they're not breathing, we readjust the airway. We look, listen, and feel. They're still not breathing. They're black. For children, we use something called Jump Start. If you have infants that aren't able to walk, obviously, they're treated as reds. We up triage children and infants and get them off the scene as quickly as possible. This sounds great on paper. In the classroom, we can just easily walk through people and assess if they're responsive, if their 32 can do is working, and that sounds great. But what if you have those emotional considerations, a hysterical patient, screaming and yelling, getting in your way? Well, sometimes they need to be made into a priority. And you have to play that by ear. Once again, this is the dynamic that makes you a good EMT. In addition, if a rescuer becomes sick or injured, then they are automatically classified as a red. if you come across patients who are contaminated, you cannot initiate start triage until they are decontaminated. Now, your decision to transport is no longer your concern as a triage officer. Since you're dealing with 50 patients, and you have to sort through them, we're not concerned about where they're going just yet. That is the role of the transportation sector supervisor, who is overseen by the incident commander. We can't send 50 trauma patients to one trauma center. That is an inappropriate way to handle resources. We need to basically have conversations with our local responding or receiving hospitals and find out things like bed status, all that stuff, before we begin transport. But that's not your role in triage. Some systems have walking wounded transported in buses, depending on the size, and they can go to one hospital. Walking wounded would not really overwhelm a hospital, depending on the type of hospital they're going to. But remember, 50 walking wounded can overwhelm a community hospital. So it's part of the incident command to actually make these decisions. So we get the red out first, we work on the yellows, move them out, and then we handle the greens. Black tag patients are taken to a separate area. Now let's talk about hazardous materials. So they get in the way of your triage. You have to triage people who are decontaminated, who are not a hazard to you or others. So you need to understand, on an awareness level, what hazardous materials are and what risks to life of not only the patient but yourself. What's your role in a hazardous materials situation? Now we talk about events, but we left out intent. There are accidental mass casualty incidences, there are natural MCIs, and then there are acts of terrorism. So terrorism is defined as an unlawful use of force or violence against persons in order to intimidate or coerce a government, to push a political agenda or a social agenda threat. And terrorism has been part of our society since recorded time. So, it always exists. We know it's there. We need to understand that whether it's terroristic, natural, or accidental, if we remove that intent, all we're left with is the event. There are different forms of terrorism. Just understand that all MCIs themselves are dynamic in nature and can be injurious to you. Just like terrorism, all different types of terrorist groups, they want to inflict as much fear and terror as possible. So how better to do that? Not only have that initial event, but have a secondary event that affects rescuers. If you think about 9/11, we had the planes hitting the buildings, but we also had the collapse of the towers. Those are two separate events that brought on extreme terror and just enhanced the fear of this nation. But it has happened for a very long time. There's all different types of terrorist groups. We have religious zealots, doomsday cults, extreme political groups. These are isolated terrorists. People who are normal, law-abiding citizens, but who are so focused on one particular socio-political issue that they will break the law to incite terror. We have our technology terrorists, hackers. all terrorists want to send their message through an act of violence. And they'd like to inflict as much damage as possible. So they like to incorporate different types of weapons of mass destruction. And a WMD is something that can bring about mass death and high casualty rates. And they'd like to do it as cheaply as possible. Economics plays a big role. There's different levels. We have chemical, biologic, radioactive, nuclear, and explosive. Those are our top 5 classifications of WMDs. So let's talk about them. So we've got our chemical. Chemical can be broken down into different types of agents. We have our vesicants, we have our respiratory or choking agents, we have our nerve agents, and our metabolic agents. Biologic terrorism deals with the release of organisms, microorganisms, viruses, bacteria, or the toxins that these bacteria or viruses create. Nuclear or radiologic terrorism, there have only been 2 incidents of nuclear use, and they were both done by this country, right? Hiroshima and Nagasaki. The ability to have it done, again, exists. It can happen at any time. The issue is it's very expensive, and it sometimes is unable to be produced by terrorist networks. But the possibility of having a nuclear device, a radioactive device, like a dirty bomb, it's very easy to create, and it can produce that effect of panic and death and injury. So we need to incorporate our same approach to everything. Forget about the intent. Focus on the event. Whether it's Superstorm Sandy, Hurricane Katrina, 9/11, the Boston bombing, or the West Texas fertilizer plant explosion. All of these types of events were massive, caused extreme loss of life, injury, and some of them cost the lives of the responders. So whether it's done naturally, accidentally, or terroristic, it's all a dangerous event, and you need to have the standard approach to it. When you go to every call, make observations. What type of location are you dealing with? How many patients you have? Pre-incident indicators. One big pre-incident indicator that can tell you it's an act of terrorism is, have you been going to the same location every day for the past 2 weeks? What's happening is, if this is a terrorist event, they're giving a dry run. They're watching your response. They're calling in a phony call. They're watching your response to that call. They're seeing where you're setting up the incident command center. And they're watching every day to see if it's the same. Then they're going to place secondary devices right in that location. So then when the real event comes and you show up and it's been 10 straight days, you probably imagine Boy Cry Wolf's going to be the same thing. They're ready to go. So don't ever be lax in your assessment, your response. Always make sure the scene's safe. Wait for law enforcement if you have to. Always stay upwind and uphill if at all possible. If you have direct contact with a WMD, you're contaminated. When you come in contact with a contaminated person, that's known as cross-contamination. So you need to notify dispatch immediately. find out what resources you have at your disposal, request anything you need right away. Estimate the number of the patients and estimate upwards. If you think there's 50, say there's 70. Don't say, oh, there's probably 20. Establish a good staging area. And for EMS, our staging area, we've got to have good egress. The purpose of ambulances, their function is to take sick people to the hospital. So if you block yourself in, you can't get the ambulance out because fire trucks have now surrounded you and they've turned on the hose lines. They're not moving. You can't get out. The ambulance is no longer an effective device. It's now just in the way. So always think, how am I going to get out of here? Where the ambulance is going to stage. It should be away from the event. Now, the first ambulance shows up at the MCI, the tech is the triage and treatment sector officer. The driver is the incident commander. The driver is also the transport, staging, supervisor. That's a lot of roles to have. So as the first arriving ambulances come in, that incident commander, driver of the ambulance, is going to have to start giving away responsibilities. But always focus on staging of the ambulance. While you're operating in the beginning of an event, you may have these multiple roles. You may not feel comfortable with them, but you still have to focus on overall patient care. And understand that a secondary device can exist. When do terrorists want to have their bombs go off? When the cameras are facing. And when the cameras all around? When the first device went off. Security experts will tell you that when it comes to assassination attempts of a dignitary, it's not about the initial attack. That initial attack is to cause panic and disrupt the order of the security systems. It opens up gaps in security that that second and lethal attack can take advantage of. So if you show up to what you feel is an act of terrorism, you have to be dynamic in your thought processes. What about those secondary devices? Now let's talk about natural disasters. There are secondary events that can occur in a natural disaster, like a hurricane or a tornado. There can be a building collapse or a flood or electrical disbursement. So you need to know when you're setting up your ambulance that you're not underneath power lines that could fall suddenly, or trees. If you go to an accidental, a fire, you need to know what's in that building that's on fire. You also have to realize about collapses. A collapse zone is twice the height of a building. So if a building is 5 stories, the collapse zone is the equivalent to 10 stories. You need to know where you're setting up your triage center, your transport sector. Where's a good, safe place to stage in case the building collapses? The World Trade Center sat a quarter of a mile in the air. So when it collapsed, the collapse zone was a half a mile in diameter. So understand that there are secondary things that can affect you as the provider. Now let's talk about some of these agents that you find. So chemical agents, we have our persistent or non-volatile agents, remain on the surface. These are usually agents that are stuck on oils that are emulsions. Non-persistent or volatile agents evaporate pretty rapidly. So the route of exposure is what we talk about in toxicology to determine how the agent got into the body. Vapors will enter through the respiratory tract. contact hazards, the volatile kind, the non-volatile kind, will actually absorb through the skin. So with vesicants, blister agents, primary route is the skin. And for instance, like mustard gas, this causes blistering to occur. And not only in the skin, but if it's inhaled, it's blistering of the respiratory tract that can cause respiratory swelling. So signs of a vesicant exposure, you're going to have irritated skin, burning, reddening, and terrible immediate skin pain like they're burning. Large blisters are formed. And this is a problem because the blisters are comprised of blood plasma. So this blood plasma is shifting across, so we're going to have a drop in blood pressure. So you can see this is a victim of mustard gas. This gives irreversible burns. This is just like they were in a fire. It also, when inhaled, attacks the red blood vessels and the bone marrow, which prevents red and white blood cell production. Now, lucite and phosgene oxime gas, very similar. The patient with this type of vesicant exposure will have grayish discoloration of the skin. For mustard or CX exposure, there's no antidote. All there is decontamination. And the best place to transport these patients to is a burn center. Now, pulmonary agents, they cause pulmonary edema, swelling of the bronchus and the trachea. Chlorine, which is, by the way, the most common hazardous material in the United States, is one of your primary pulmonary agents. Chlorine gas, once again, you've got to think about how you can get chlorine gas, how you can inhale chlorine. It can be something from an accidental train derailment. It can be from a patient who just opened up their pool for the first time, popped open the HH chlorine, and it was partially open, and the chlorine gas had permeated into the garage that had been sealed all winter, and now suddenly they're overwhelmed by chlorine gas. Or it could be an act of terrorism, whatever. Okay? Patients are going to experience shortness of breath, chest tightness. Remember, when you mix chlorine with water, you have hydrochloric acid. So when you inhale chlorine, it mixes with the natural water in your respiratory tract and creates acid burns. Phosgene is a pulmonary agent as well as a vesicant. Very potent. Mild exposure can cause horrible burns to your respiratory system. So when these patients are treated, you've got to remove them from the irritant and rapid assessment. These patients probably require advanced life support management for airway control, intubation. There are no antidotes for this, and if someone has powder on them, we want to dry it off as quick as possible before we flood it with water. Just a little bit of water, like having them go into a shower where they're trickling, will activate the chlorine and turn it into hydrochloric acid. Nerve agents, they attack your body's autonomic nervous system. They cause you to stay in parasympathetic tone. Your autonomic nervous system is either the sympathetic, the fight or flight, or the parasympathetic, the feed or breed. So fight or flight is regulated by epinephrine and norepinephrine, and it increases your heart rate, your blood pressure. It causes you to initiate a stress response, whether you're going to attack your opponent or run away from your opponent. We'll make that decision, but it gives you the ability to do so. And the feed or breed, the parasympathetic, is the relaxing on the couch, eating potato chips, watching TV. It's our default setting. Sounds pretty benign. It's part of digestion, everything like that. You're just relaxing. Lowers your heart rate. It's actually where we all want to be. But what these agents do is that they overstimulate the parasympathetic nervous system, and an overstimulation of this system will cause what we call sludgeum. Another problem with parasympathetic tone is that our bronchioles constrict. During sympathetic tone, they dilate because we have to breathe more, but they constrict just a little bit. But if they're overstimulated, it's an overconstriction that can lead to bronchorrhea, which is basically a suffocation. So these different agents, we have our G series, sarin gas. You might have heard of it recently this year. It was reported to have been dispersed in Syria. It was also used in Iraq in the early 90s. Soman, 5 times more lethal than sarin gas. GA is half as lethal as sarin. And the worst one out there is VX. It's 100 times more lethal than sarin gas. The amount that can fit on a penny, just enough to cover the date of minting, that's all you need to kill everybody in a 50 square foot space. Now, what do? They overstimulate the parasympathetic nervous system, and we get an overstimulation of digestion. Salivation, sweating, lacrimation, urination, defecation, gastric upset, emesis. So that's all GI. In addition, we get terrible muscle twitches because acetylcholine is a neurotransmitter of the parasympathetic nervous system that's being overstimulated, but it's also a neurotransmitter of your musculoskeletal nervous system, known as the somatic. So having this acetylcholine intensify will cause the muscle twitches. But what are we really concerned about? That's not listed here, but it's on the dumbbells. Bronchospasm. So our treatment is a duodope, atropine and 2-PAM. And what atropine does is it blocks this acetylcholine. And what 2-PAM does is that it preserves the enzyme that breaks down the acetylcholine so it won't overproduce. That enzyme is known as acetylcholine esterase. The only way you can get acetylcholine off of the affected organs that are now being overstimulated is with acetylcholine esterase. And nerve agents kill that enzyme. Now the problem with that is you can't make any more acetylcholine esterase. So we don't want to become affected because there's no cure for a nerve agent exposure. There's only rapid treatment and prevention. So that's why we give ourselves the autoinjector first if we find ourselves in contact. Now some metabolic agents that we're dealing with. Hydrogen cyanide and cyanogen chloride. These get in the way from the bodies, from the cells of the body being able to use oxygen to create energy, to create ATP, that Krebs cycle. So if the body can't use oxygen, even if you have a lot of oxygen, it's going to start going anaerobic and just burn sugar. And eventually, it's just like hypoperfusing, the patient will die pretty quickly. Now, what will happen with these patients come in contact, they'll show signs and symptoms of compensatory shock. Tachypnea, tachycardia, they can actually go apneic, comatose, and then full cardiac arrest. So cyanide agent treatment, unlike the nerve agent toxins, we have actual antidotes for that. Paramedic units carry them. Cyanide toxicity kits. Depending on your region, you'd want to find out who carries this, but it's got to be given IV. It's basically a vitamin B supplement that's given that actually supports the cell's ability to burn oxygen now. Realize that with cyanide, if it's on the skin or on clothing, it will off-gas. So these patients have to be decontaminated. Biologic agents, these are now a cheap way to kill a lot of people and to make a lot of people sick, but it's not really sending a message. So you don't see it used a lot, because how do you know if it was an accidental or intentional? But really, this is a mass destructive agent. It can kill a lot of people. The ability for a biologic agent to go from one person to another is known as communicability. Incubation is the period of time the patient is exposed to when they start showing signs and symptoms. Now, these biologic agents that are out there, viruses. Viruses are basically parasites that require a living host to survive. It shares the host's DNA and replicates with that host cell's DNA. A lethal virus out there is smallpox. Smallpox has a 14-day incubation period. It's what people in Homeland Security are very concerned about, because somebody could be showing no signs of symptoms but be highly contagious. Imagine this person flying into the United States during Christmas, landing at JFK Airport, walking around JFK Airport, going into the city and walking around the mall, just shopping, and then going back to JFK and flying back. Imagine all the people from all the different countries that this person's been in casual contact with for a period of 1 or 2 days. Before even showing signs of symptoms, they have created a widespread global outbreak of smallpox, which could be lethal, which could kill hundreds of millions of people. We have other types of viruses, like VHF, otherwise known as viral hemorrhagic fever, causes the blood to actually seep out. A very common one is known as the Ebola virus. So viruses need a host. Bacteria, on the other hand, don't need a host. They're a living organism that are multiplying. They'd like to have a nice environment to live. Unlike viruses, we can fight bacteria with antibiotics. One common bacteria that was heard a lot about post 9/11 is anthrax. Anthrax is naturally seen as a surface bacteria. It develops on the skin, and you can see this picture. It makes a pustule that looks like a lump of coal. Hence the name anthrax, which is Greek for coal. What happened was they weaponized this bacteria and put it into a spore. So it had the environment, it bred inside this microscopic spore, and then it dispersed the spore and you inhaled it. When you inhale the bacteria, now it goes into your bloodstream, it opens up and it propagates through your blood, and if you have a low immune system, it can kill you. Strong antibiotics have been able to treat it very effectively. So the way that weaponized anthrax is sent out, is dispersed, is an aerosol in that pod form. And victims of anthrax exposure or weaponized anthrax inhalation will develop flu-like symptoms, fever, but it can lead to pulmonary and respiratory failure. And our management, really for pulmonary, they need to be ventilated, intubated, ICU admission, and they get IV antibiotics. Cipro is one of the primary antibiotics that's used to combat this bacteria. Another type of bacteria out there is the plague, like the bubonic plague or the pneumonic plague, naturally dispersed through rodents or fleas, and then from there the bacteria through flea bite or rodent infestation will transfer over from one species to another. And this is what you see physically with patients who have the plague. So it's disseminated, it's an aerosol dissemination, so it's, with the communicability of bubonic, unless you come in fluid contact that has this bacteria, you won't get it. With pneumonic, it's very high. Medical management, antibiotics work very effectively to combat this type of bacteria. Now, bacteria themselves can cause damage, but primarily bacteria secrete waste products, and these toxins can affect the disease processes of the body and have a major neurologic issue. One toxin that's a strong neurotoxin is botulism. Produced by bacteria, affects the nervous system, and you lose your skeletal muscle control, and it can lead to musculoskeletal paralysis, and severely the diaphragm will become paralyzed, leading to respiratory arrest. Botulism can be aerosolized. There was actually a group in a suburb of Seattle that was a doomsday cult that wanted to sway an election, so they sprayed botulism on all the salad bars. And while a lot of people got sick, nobody died, fortunately, and also the cult was caught and they all went to jail. Ricin, it's withdrawn from the castor bean, and it causes pulmonary and circulatory collapse. It's a stable substance. It can be stored for a long time. It's extremely toxic. Just takes a little bit to cause pulmonary collapse. It's disseminated once again by aerosol or contamination. It's not communicable from one person to another. It has to be direct transmission. If it's inhaled, you have immediate respiratory issues. If it's ingested, we start off with nausea, vomiting, internal bleeding, but then triggers into respiratory. And if it's injected, you'll have no signs at the injection site, but the patient will go into respiratory failure. There's no treatment or vaccine available except supportive care and hoping that naturally the body can combat it. So these are all different things that we find. Now, from our perspective in emergency medicine, we also have to be public health advocates, and we have to be public health reporters. And doing good documentation will allow us and the public health agencies to have what's known as syndromic surveillance. I'm not saying that every EMT should go around and see how many people are getting sick where, but all the data that's collected from your good documentation will help public health agencies to determine if there is an outbreak. The way the government has the situation now with the Food and Drug Administration and the CDC, they have what are called pods, points of distribution. And they have, in addition to antibiotics and antidotes, they have vaccines and other medications. There are hospitals and facilities that are partnered with the CDC to store these pods. So they're strategically placed around not only New York City, but across the country, and they coordinate with the local EMS and fire agencies and the Office of Emergency Management to, if there is an actual issue, there's a deployment of a nerve agent or a biologic disbursement, that they can withdraw these pods from their containers in their holding facilities at these different secure hospitals and be able to disperse them to the public. When we talk about radiologic or nuclear devices, we have four major particles we deal with: alpha, beta particles, gamma rays, and neutron particles. The most powerful are neutrons and the least harmful are alpha. You can see from the picture, alpha particles can actually bounce off of paper. Beta particles, if you're wearing clothing, they bounce off clothing. Beta particles really get their potency if they're inhaled or ingested. Now, radiologic substances are found everywhere, not just in nuclear devices, but they can be found in hospitals, nuclear medicine, industrial sites, colleges, and universities. And all you need to do is have a radiologic substance and put it on a device. It could be something as rudimentary as a pipe bomb. The explosion and the shrapnel and the dust becomes ionized, radioactive, and it goes into the environment and spreads. This is what's known as a dirty bomb. So nuclear energy is an atom that has been altered or split, as they call it. The issue with this, the energy that actually comes as a result of splitting an atom is incredible and devastating. It can be controlled, though, in nuclear facilities where they undergo fusion reaction or fission reaction of splitting the atom, and it's in a controlled environment. It can create incredible power that can be harnessed for power consumption needs. But it can also be weaponized. And these nuclear weapons, they need to be in secure facilities. We hope that no rogue nations have nuclear weapons, or if they do, they don't have the ability to have propulsion to send them to this country, but it is possible. Exposure to radiation will vary depending on the amount of radiation, the route of entry, and the distance and the shielding. Being exposed does not mean you're contaminated or radioactive. But if someone has a radioactive substance on them, they need to be decontaminated. Being exposed to something like a gamma ray. Gamma radiation doesn't leave any product on the patient. Instead, it's a ray that went right through the patient and denaturized the cells, and can cause cancer, it can cause problems with DNA structure, genetic problems. So we need to understand that there's nothing that you can completely protect yourself from all forms of radiation. Neutrons, gamma rays, they will go right through all shielding. All you need to know is if you have enough distance, you're far enough away, you're fine. So you take direction from the radiation specialist in the scene, that will tell you. Some systems have Geiger counters that can tell if you are too close to a radioactive source. So you walk away until the Geiger counter goes to it signals a lower or acceptable radiation form, known as background radiation. Then you know you're far enough away. Final thing we'll talk about is incendiary explosive devices. We saw the devastation that can occur with a rudimentary explosive device using a pressure cooker and fireworks at the Boston Marathon in 2013. When you're dealing with an explosive agent, you have to recognize before it's exploded that it exists and be able to evacuate the area. And always remember, as a provider, that they're not looking for that initial blast. That's to draw media in and responders in and rescuers in. The second device is going to be bigger and it's going to cause more damage. It's going to be spectacular. It's going to take more life. They want to suck you in, so be careful of that type of situation. Severity of wounds is correlated with the distance and a shielding from that explosion's epicenter, where it occurred. People who are closer will have more injury. There's blast injury, and that's your primary blast. That's your primary injury. After that comes secondary, which is any shrapnel that was produced by the bomb, either contained in the bomb or the bomb itself, the shards of it. That's your secondary. Then you have your tertiary, okay, which is what you got blown into. The force can blow you onto the ground, it can blow you into a wall or through a pane of glass. That can cause damage on itself. And then we have our quaternary, which is anything that's in the bomb, like radiation, that is now affecting you and causing a disease process. So take everything into account. Remember that no matter what the intent is, you have the event to deal with. Be focused, be aware that there's secondary issues, there's other dangers. The primary issue in operations is your safety. Once your safety has been assured, and with your safety in mind, you can provide optimal care and make it home to be with your family. Thank you.